Welcome to This Explainer. Look, as neonatologists, we all know the sinking feeling when a newborn's cardiopulmonary transition just fails. Today, we're zeroing in on that exact neonatal emergency, persistent pulmonary hypertension of the newborn, or PPHN. But here's the thing. The way we handle this crisis, it's completely shifted. We've left behind some of those older, honestly pretty dangerous practices for a highly targeted, modern paradigm that is literally transforming outcomes in the NICU. Let's get right into it. Here's our clear, protocol-driven roadmap for today. We'll start with the circulatory transition failure, break down the etiology, and talk diagnosis and echocardiography. Then we'll explore the gentle ventilation paradigm before escalating to vasodilators and inotherapy, and finally wrap up with ECMO and long-term follow-up. All right, Section 1, the circulatory transition failure, when normal adaptation fails. So, successful extrauterine life is completely dependent on pulmonary vascular resistance dropping rapidly right at birth. We all know this. But when that adaptation fails, that resistance stays stubbornly high and it forces deoxygenated blood directly away from the lungs. You can clearly see the right-to-left shunting happening across both the patent foramen ovale and the patent ductus arteriosus here. And that is exactly what creates the severe ventilation-perfusion mismatch and that profound refractory hypoxemia we end up battling at the bedside. Moving on to Section 2, etiology of PPHN, the three categories. Now, while about 15 to 20% of PPHN cases are totally idiopathic, happening in structurally normal lungs, the vast majority are secondary. It really helps to mentally group these root causes into three primary buckets: underdevelopment, maldevelopment, and maladaptation, the three M's and U's. Grouping your patients this way is a game changer because it immediately informs your expectations for their clinical course. Underdevelopment involves a reduced cross-sectional area of the vasculature. Think congenital diaphragmatic hernia. Next is maldevelopment, which features abnormally thickened musculature in otherwise normal lungs, and that's strongly associated with meconium aspiration syndrome or post-term deliveries. Finally, maladaptation. This is active vasoconstriction driven by parenchymal disease, like RDS, pneumonia, or sepsis. Section 3, diagnosis and echocardiography. Identifying PPHN. Here's the tricky part. The clinical presentation of PPHN often perfectly mimics cyanotic congenital heart disease, requiring really rapid differentiation. The classic clinical hallmark you're looking for is labile hypoxemia. That's a massive swing in oxygen saturation with basically zero change in your ventilator settings or FiO2. Why? Because of those tiny constant shifts in that incredibly delicate balance between pulmonary and systemic vascular resistance. You also want to look closely for differential cyanosis, a preductal versus postductal saturation difference, where the lower limb is more than 5 to 10% lower than the right upper limb, is a glaring clinical marker of right to left ductal shunting. To confirm our clinical suspicions, we turn to the absolute gold standard, the echocardiogram. The echo is really pulling double duty here. It confirms normal cardiac anatomy to rule out structural heart disease, while simultaneously revealing the functional hallmarks of elevated right-sided pressures. You want to look closely at right ventricular function, measure that tricuspid regurgitation velocity, and definitely check for that classic flattening or leftward deviation of the interventricular septum. Okay, Section 4, the gentle ventilation paradigm, a shift in practice. This is where the massive paradigm shift comes in. How we support these lungs today looks totally different than it did 2 decades ago. We've got to contrast our historical approach with today's standard. In the past, the strategy relied heavily on hyperventilation, hyperoxia, and pushing alkali infusions to induce alkalosis. Well, we now know those practices have severe adverse effects on cerebral perfusion and actually spike the risk of sensory neural deafness. Today, we rely completely on the modern, evidence-based strategy of gentle ventilation. We optimize lung volume recruitment with appropriate PEEP, we allow for permissive hypercapnia, we minimize oxygen toxicity, and we maintain the pH optimally between 7.30 and 7.40. It's all about avoiding exaggerated hypoxic pulmonary vasoconstriction without damaging that incredibly vulnerable newborn brain. Moving to Section 5, vasodilators and INO therapy, escalating interventions. So what happens when optimal supportive care and gentle ventilation just aren't enough to reverse the hypoxemia? We have to escalate and target the vascular endothelium directly.
By mapping out these cellular pathways, we can see exactly how endothelial nitric oxide synthase, or eNOS, normally functions to stimulate soluble-guanylate cyclase, increasing cGMP to cause vasodilation. When this natural process gets suppressed in PPHN, we deploy targeted therapies to intervene. Inhaled nitric oxide supplies NO straight to the smooth muscle to drive cGMP production. Sildenafil inhibits PDE5 to prevent the breakdown of that cGMP. And on the flip side of the pathway, milrinone inhibits PDE3A to prevent the breakdown of CAMP. It's a beautifully mechanistic, highly targeted approach to forcing that smooth muscle to relax.
But the real question is, when exactly do we deploy these tools? We frame the treatment algorithm as a very logical clinical escalation based strictly on oxygenation index, or OI thresholds. For an OI less than 25, hold steady with supportive care and gentle ventilation. Once that OI hits 25 or greater despite your optimal ventilation, it is time to administer INO, typically starting at 20 parts per million. And if the OI reaches 40 or greater, you are now dealing with severe refractory hypoxemia, and you absolutely must prepare for rescue therapies like ECMO. Sticking strictly to these OI thresholds removes all the guesswork from your escalation strategy.
Finally, Section 6, ECM and long-term follow-up, rescue and recovery.
For the most severe cases of refractory PPHN, where maximal ventilatory support and inhaled nitric oxide have just failed to resolve the critical hypoxemia, we look to ECMO. The widely accepted institutional criteria are pretty clear: an oxygenation index of 40 or greater, a birth weight over 1,800 grams, a gestational age greater than 34 weeks, a reversible lung disease process, and no evidence of cyanotic congenital heart disease. But it is vital to remember this: ECMO isn't a cure itself. It acts as a crucial bridge. It maintains adequate oxygen delivery to the tissues, allowing the pulmonary vasculature the necessary 7 to 10 days to remodel, all without the ongoing lung injury caused by maximal mechanical ventilation. But here is the reality check. Our job as neonatologists isn't done just because they survived the acute crisis. We must look past acute survival. These high-risk PPHN graduates, especially those who required INO or ECMO, absolutely demand strict 6 to 12-month neurodevelopmental assessments and formal hearing evaluations by 18 to 24 months due to the massive risks of both the disease and our therapies. So as we master the acute cardiopulmonary physiology inside the unit, we really must ask ourselves, are our outpatient follow-up systems actually as robust as our NICI protocols to ensure these vulnerable infants truly thrive long-term? Thanks for joining me on this